Dear colleagues, it's a pleasure to give this FAI²R webinar on the important question of the initiation of targeted therapy, such as biologics, in patients with systemic autoimmune disease or inflammatory rheumatic disease and a history of cancer. Please find here my disclosures. So I'm Jacques-Eric GOTTENBERG, a rheumatologist in Strasbourg. And the subject of the connections between cancer and systemic autoimmune disease or inflammatory disease are very numerous. You all know the paraneoplastic syndromes, the autoimmune disease induced by checkpoint inhibitors, and you know that some cancers are their risk are increased in patients with systemic autoimmune diseases. And this is true for rheumatoid arthritis, where the risk of lymphoma or lung cancer is increased. This is also true for other systemic autoimmune disease like Sjogren's disease, like systemic lupus, and so on. Let's now move to the question of the risk of cancer in patients treated with a targeted therapy, biologic. Actually, after more than 20 years of using a targeted therapy, only the risk of non-melanoma skin cancer has been evidenced for some targeted therapies, but it's true also for other conventional immunomodulatory treatments. What we really do not know very well is the risk of recurrence of cancer or new cancer in a patient with a history of cancer who is treated with a targeted therapy, because we can speculate that in such a patient the immune system is controlling cancer and could be destabilized by the introduction of a targeted therapy that could dampen anti-tumoral immunity. And maybe this risk of dampening tumoral immunity, anti-tumoral immunity, is not exactly the same for some cancers, for example in melanoma or breast cancer, or not the same depending on the targeted therapy. Or the cytokines that are targeted, or the cellular populations that are targeted. And this situation of a history of cancer is really increasing since the population is aging, and since the survival, and here in an example on the right hand side of the doubling of the overall survival in patients with renal cancer over years. So more older patients, patients that survive now. This situation is now nearly a daily concern for us working in internal medicine or in the rheumatology field. The problem is that since we do not have any data, or few data, as we will see soon, limited data in patients with history of cancer that were excluded from the clinical trials evaluating targeted therapies, we are more or less reluctant to prescribe a targeted therapy in patients with history of cancer, and this may lead to an insufficient control of disease activity of the systemic inflammatory disease, and this may, in turn, inflammation itself may increase the risk of cancer. So it's really important to have some guidance and to try to review the current literature on the subject of patients with a history of cancer. And that's exactly what we did with the EULAR, using the EULAR EULAR methodology and the task force, the EULAR task force, because we felt that there were so limited recommendations. Here an example of the recommendations in the IBD domain, where they ask for caution and to wait for between 2 and 5 years. And the same holds for the current French recommendations, where it is stated that it is better to wait, if possible, 5 years before introducing targeted therapy. So with Eden Sebag, we coordinated a EULAR task force, and I really thank all the participants of this task force who did really a great job. We had patients representative, methodologists, experts of real-world data, and oncologists, and we made a systematic literature review, not only in the rheumatic inflammatory field, but also in patients with inflammatory bowel disease or with psoriasis. And the inclusion criteria were to have studies including patients with a history of cancer treated either with a conventional DMARDs or a targeted therapy. But we knew that we will end up with a limited number of studies, so we decided to also take into account some other data based on translational research, on data on the incidence of cancer in patients without a history of cancer under targeted therapies, and on the data that we have regarding the use of targeted therapy to treat immune-related adverse events related to checkpoint inhibitors. Here's the flow chart of the systematic literature review. We started with 1,000 and more than 500 papers, manuscripts, and we ended with 15 studies. And most of these studies concerned the anti-TNF. You can see the number of patients here. So we had 8,000 patients treated with conventional DMARD, and 4,000 treated with anti-TNF, and very few patients treated with other biologics. Most of these studies concerned rheumatoid arthritis and anti-TNF, and I insist on this fact, cancer in remission, and the median follow-up of the patients in these studies were around 3 years, which is not large when we analyze cancer, and we know that the risk of recurrence of cancer is really can occur a long time after the diagnosis of cancer. So these are the results of the meta-analysis of the systematic literature review. We pulled the risk of recurrence of cancer and new cancer, because in most of the studies it is pooled, so it was difficult to discriminate recurrence between new cancer. And the result of this meta-analysis is that there's no significant increase in the risk of recurrence or new cancer in patients treated with a biologic, and it was mostly anti-TNF, compared with patients treated with a conventional DMARD like methotrexate. Since this systematic literature review included papers until 2022, let me just summarize 3 very nice papers that were published ever since. First, a manuscript study from an American group worked specifically on patients with breast cancer. That's very interesting because most of the studies in the meta-analysis pooled different types of cancers. Here it's breast cancer and early breast cancer, and they had a lot of patients, around 1,000 patients, and compared the overall survival at 5 years between patients treated with anti-TNF, methotrexate, or none of these two, and there was no significant difference, no significant increase in patients treated with anti-TNF. And they also published a study on colorectal cancer, lung cancer, and prostate cancer this year, and they very carefully analyzed at 1 year, 2 year, stratified based on different risk factors, and did not see in each of these cancers an increased risk with anti-TNF regarding the overall survival, which was similar compared to conventional DMARD. this is the result of the overall survival at 2 years, which was not significantly different. Last, the very interesting publication from the Danish registry, which compared for patients with a history of solid cancer, anti-TNF and rituximab and conventional DMARDs for the risk of recurrence. Here they specifically, and it's really interesting, analyzed the risk of recurrence. They did not pool with the risk of another new cancer, and there was no significant difference regarding the risk of recurrence in patients treated with anti-TNF, with rituximab, or with a conventional DMARD. Let's come to the EULAR points to consider that we recently published in Annals of the Rheumatic Disease, and I thank again all the task force who did really a great job. These are the overarching principles where we insist on the importance of discussing with oncologists and the shared decision with the patient. And we also insist that we have to balance the risk of recurrence or new cancer with the risk of persistent inflammation, for which is disabling the patient and may result also in increasing the risk of cancer and increasing the risk of the corticosteroid intake, which is really not a good thing. And let's now move to 2 or 3 very specific points where we try to be very practical and to change the way to handle this situation of history of cancer based on the systematic literature review. First, we stated that an appropriate targeted therapy can be initiated without delay in a patient with a history of cancer in remission, and that's really this was allowed by a subgroup analysis of this meta-analysis, since there were 5 studies where targeted therapy was initiated less than 5 years after the diagnosis of cancer. And we did not see, even in this subgroup analysis, an increase of the risk of recurrence or new cancer in patients treated with anti-TNF compared to patients treated with a conventional DMARD. So that's really important. That means that this is not the number of years since the diagnosis of cancer or since remission that is important. What is important is to really weigh the benefit-risk ratio based on individualization. What is the risk for this patient with this type of cancer? How important is the disease activity? And then to have a good discussion. And it's not let's wait because it's been only 3 years since the diagnosis of cancer. It's really case by case, patient by patient. We were very cautious with JAK-STAT inhibitors, since we said that they should be used with caution, and when there's no other alternative. This is really based first on the fact that we do not have any data in patients with a history of cancer. And the second reason is that in patients without a history of cancer that were excluded from this trial, the oral surveillance randomized trials showed an increase of the risk of cancer in patients treated with tofacitinib compared to patients treated with anti-TNF. And likewise, in real life, recently, the Rabbit registry, the German registry, showed also an increase in the risk of cancer in patients treated with JAK inhibitors compared to a biologic DMARD. You can see here on the right-hand side. And again, after a certain period, here it was 16 months. In the oral surveillance trial, it was 18 months. So let's be according also to the PRAC recommendations, the other European recommendations. It's clearly not the first class of first mechanism of action. Blocking JAK-STAT inhibition, blocking JAK-STAT in patients with a history of cancer cannot be the first line in a patient with a history of cancer. we were also cautious with abatacept. First, we do not have any data in patients with a history of cancer. Second, and it's only observational data, and they have discordant results, but there is a signal in patients without a history of cancer of a mild increase in some studies of cancer compared to anti-TNF or compared to conventional DMARD or to the general population. So again, it's really a mild signal, but there is a signal, and we have to wait more and have data on patients with history of cancer also treated with abatacept before being able to recommend more. We also said that in patients with a history of solid cancer, based on the studies that we had in the meta-analysis, which were mostly concerned anti-TNF, and also based on more recent translational data saying that B lymphocytes may be more important than we thought to protect us against cancer, we said that anti-TNF should be preferred to B-cell depletion in patients with a history of solid cancer, for example, colon cancer. Melanoma was excluded because there were too limited data in patients with melanoma. Of course, in patients with a history of lymphoma, rituximab should be preferred. This was another recommendation. So this is the way we propose to handle the situation of initiation of a targeted therapy in a patient with a history of cancer. First, really weigh the benefit-risk ratio and in collaboration with the oncologist and in a shared decision approach. And in case of history of solid cancer, we prioritize anti-TNF. We had a lot of discussions about anti-IL-6 receptors, but there are really limited data so far. And in case of a history of lymphoma or hematological malignancy, prefer rituximab as a first line. Of course, the research agenda remains important, and we have all to generate more data in patients with history of cancer treated with treatments that are not anti-TNF, in systemic autoimmune diseases that are not rheumatoid, that is not rheumatoid arthritis. We also want to, it's also important to increase the duration of follow-up, and perhaps to set up some meetings to discuss the more complex cases, and this could be perhaps organized with the help of the Filière FAI²R. And that said, I really want to thank you for your attention, and to thank again Eden Sebag, who coordinated these EULAR points to consider with me, and all the patients and colleagues that participated to this task force, and others that participate to the EULAR study group on rheumatic malignancy, rheumatosskeletal disease and malignancy. Thank you for your attention.